Okay, I think we'll get started. Thank you everybody for joining. My name is Susan Park, and I'll be doing just kind of some housekeeping before we start. Next slide. So sorry, let me see. All participants will be muted. To ask a question, feel free to unmute yourself or leave a comment in our chat box, and then we can have a Q&A at the end to address those. This webinar is being recorded, and at the end there will be an evaluation link that is also dropped to get feedback on this session and future sessions. Next slide. So we'll go ahead and do an icebreaker. So this is meant to be truly a collaborative. So we have, different levels of stakeholders, providers, health systems, researchers here. So we kind of want to find some common ground. So we'll do a little icebreaker. So what is on your summer bucket list? And then please include your name, organization, and role. Next slide. Okay, and so this learning opportunity is being brought to you by our Engaging Health Systems and Provider Work Group. We're all members of a larger group called the California HPV Vaccination Roundtable, our goal being to work towards preventing HPV-related cancers. And so we're going to be picking topics related to HPV vaccination promotion and prevention. If you are asking, well, what is that we do? Well, we have various stakeholders with the mission to work together to prevent HPV-associated cancers. And we're trying to meet a metric set out for 80% by 2026 vaccination. If you want more information, there's our website. So I'm going to go ahead and move on toward our roundtable updates. So there's a few things that are going on in our organization. Very soon we'll be having a vaccine week campaign from August 3rd through August 9th. And we're going to be promoting the Start at 9. And why age 9? Because we realize that it can improve vaccination rates overall. And so it'll be a myriad of sessions that talk about strategies, case presentations, and the Q&A. And this is meant for everybody, so not just providers, but public health, community partners, and advocates. So hopefully you can go to at least a few of the sessions that are available then. Next slide. Some other things that we're working on is the announcement approach training. So this is a program that we can offer to your facility, where we have a trainer that can go teach your providers, front office staff about how to do what's called an announcement approach training of how to make HPV vaccine recommendation. It's online, it's 1 hour, and if you're interested, it is tied to CME. We can help you schedule a session at your site. Next slide. And then I think next slide. So again, I think we talked about this. California HPV Vaccine Week will take place August 3rd to 9th. And this is something that they'll also be tied in with a social media campaign. So we will ask for your help to kind of spread the word. Next slide. This will include websites, webinars, social media toolkit of how you can help spread the news, and the campaign guide.
Susan, I think Bridget is on the line as well. Bridget, would you like to share more?
Okay, okay. My bad. That's me.
No worries, Dr. Park. You're doing a great job. I'm happy to.
The slides weren't there the first time. I'm sorry about that. So I will ask, I'm supposed to introduce you. So this is kind of the table's turn because I've had Bridget introduce me a few times, but I'm very happy for you to Cancer Society and committee who helps to promote a lot of these. So vaccine. Thank you.
Great. Well, thank you so much, everybody. So I'm Bridget Freely. I'm an Associate Director of State Partnerships at the American Cancer Society, and also have the pleasure of sitting on our California HPV Vaccination Parent Work Group, who leads these efforts. And as Dr. Park mentioned, one of our biggest efforts as the Parent Work Group is our signature annual public awareness campaign that's led by the Roundtable. It's called California HPV Vaccine Week. It takes place the first full week of August, which is coming up very fast. And the goal is to raise awareness of the HPV vaccine as cancer prevention and promote HPV vaccination of kids, really focusing on ages 9 through 12 throughout the state. So this year it's running August 3rd through 9th, and so we're gearing up for that and just wanted to share some resources we have available. So as you'll see on this slide, we've created a variety of materials that really want to help our partners, and that includes coalitions, health systems, health plans, primary care providers, advocacy groups, really anyone doing HPV vaccination work to help promote the importance of HPV vaccination during vaccine week, but also beyond. So some of our offerings are a dedicated website on our Roundtables website that has all of our HPV vaccine week resources. We have social media resources with HPV related cancer survivor stories and social media graphics. Our roundtable also has a social media account, and we encourage you to follow us. Our social media account information is on our website, just so that you can, kind of co-share these assets or share them yourself during the week on Instagram and Facebook. We have our dedicated campaign guide that lives on our website. This is a PDF document we created with key messaging examples such as newsletter content, content for email, e-blast that might be going out to your membership or providers, as well as links to resources and external learning opportunities as well. And I do want to note that our campaign guide hosts all of our social media content as well as suggested captions for that content. And we also do work with key partners throughout the state to host webinars. I know the Start at Age 9 webinar was just mentioned as well. I just wanted to show you a few screenshots of the pieces I mentioned above. So this is just some screen grabs of our website. And again, this lives on our existing California HPV Roundtable website. I put the link here. Our web team is just making a few final cosmetic edits to the website, but I do want to say our 2025 toolkit is up and available as well as our resources. So please feel free. I can pop the link in the chat to go in and start looking at everything and seeing how you might be able to share these resources during the week. We can go to the next slide. These are some screenshots of our social media offerings. Here you can see all of our stories from our HPV cancer survivors. We have both still images and as well as videos that you can share on social media or share in other capacities as well. I know some individuals have shared them at meetings or even in clinic waiting rooms. These individuals were identified by members of our parent work group, and we also just developed talking points to help them streamline their storytelling, but also make sure that it's personal to them. So as you'll see, we have a variety of HPV-related cancer survivors. We have a story in Spanish as well, and then we also have a medical provider as well. And I will just say storytelling is probably one of our most powerful assets. We can go to the next slide. These are just some snippets of our fact-based posts available. These are just kind of more general HPV vaccine messaging, graphics for social media. We do have them available in English, Spanish, and Vietnamese as well. And I do want to say that while some of our assets mention Vaccine Week, the majority of them do not. So they can be used outside of Vaccine Week as well. We don't want you to feel that you can only share them during August 3rd through 9th. Please use these throughout the month of August, later on, really whenever they're relevant to your work. We can go to the next slide. I just want to share a little impact that we've had over the last couple of years. We did have some dollars to do paid ads on social media with some of the content you just saw. And as a result, we were able to reach over 1.7 million people in California communities and hundreds through our webinar efforts, which is really great. We can go to the next slide. This year, unfortunately, we don't have the same amount of dollars to do this work, but we really, as a group, put our heads together to figure out how can we still maximize our efforts and get the stories out there that are needed. And we are doing a call to action for stories from HPV-related cancer survivors, parents, young people, providers, really anyone who's passionate about HPV vaccination. And we're asking individuals essentially to record a 30 to 60-second video of their story, share on their social media during Vaccine Week, that August 3rd through 9th time period, and tag our Roundtable social media accounts and use our designated hashtags so that we can reshare and really track who's sharing their story and still get the message out about the importance of HPV vaccination far and wide. We have some instructions. I just put a snapshot here. These are available in our toolkit as well, so that you can take a look. And if you want to share your story or know someone who might want to, that they can easily do so. We're also this year trying to identify some media spokespeople and working with our American Cancer Society marketing team to get out the word about that during Vaccine Week as well. So more to come there. And then I think just one more slide. I know the slide was already shared, but just a reminder, on August 7th, there is a Start at Age 9 webinar. Put the registration link there, and we hope that you can join us. And I believe that's all I had. Just thank you for letting me share this. Thank you to, and I just want to say a huge shout out to the team who made this happen. Kim Woodster-Chill, Margot Stack-Babich, Jane Gray, Raquel Arias, and Shantae Joyce and Sheila, and the Health Systems and Provider Work Group as well. So thank you all, and I'll pass it back to you, Joyce.
All
Or
right,
Dr.
thank you,
Park, I'm
Bridget.
sorry.
Yeah, yeah, that was so much better. I could feel like I don't remember those slides, so appreciate you taking over. But I do have the pleasure next to introduce Dr. Corine McDaniels-Davidson. So I met her through ASCCP and learned about her amazing work that she's doing down with her team in San Diego. But to formally introduce her, she's an associate professor of health promotion and behavior sciences at San Diego State University and the director of the San Diego State University Institute for Public Health. And she's here today to talk about a creative way that we can promote vaccination. So empowering medical assistants to improve HPV vaccinations, results of a California needs assessment. Thank you, Dr. McDaniels, for joining.
Thanks so much for having me. I'm going to share my slides. Give me 1 second.
Corine, your volume's a little low. I'm wondering if you can increase your mic.
Let me find out. I can also speak a little closer. I'm using a new computer. Please accept my apologies. Okay, I turned up my mic. How's that?
Better, thank you.
Thank you. So I'm thrilled to be here today talking with all of you and seeing so many familiar faces on the participant list. So thank you so much for having me. I'm going to talk a little bit about HPV vaccination, which most of you are very well familiar with. And then I'm going to talk about vaccine misperceptions, this idea that it's a little bit of hesitancy, it's a little bit of misplaced knowledge, and we'll talk a little bit about that. And then I want to talk about frontline clinical staff and what their role is. And then I'll tell you about a study that we just wrapped up that I'm so excited about and take you through kind of what my thinking is there. So we'll start. As you all know, there is nearly 38,000 HPV-associated cancers diagnosed each year in the United States, nearly 700,000 worldwide. This chart is showing trends over time for the proportion of 13 to 15-year-olds who receive at least 2 doses of the HPV vaccine. Boys are the blue diamonds and girls are the orange triangles, and you can see the Healthy People 2020, later the Healthy People 2030 goal of 80%, shown by the red line at the top. And then you can also see what was happening in the regulatory world at different times. So Gardasil 4 was approved for use in 2006, and it was a great vaccine, but hindsight suggests that we may have bungled the messaging. It protected against 4 HPV types that cause the most common or the most cases of genital warts, 6 and 11, and the 2 most common oncogenic types. And while its approval only in girls made scientific sense based on the trials and the endpoints that were used, it may have suggested to people that this was a vaccine for a girls' problem that was caused by sex. And so pediatricians were understandably nervous about it. There wasn't a lot of broad buy-in from that critical group of colleagues, and this may have been partly because they don't typically see the downstream effects of HPV infection, because cancers are slow to develop and generally happen later in life. And many of them didn't recommend it or hemmed and hawed when asked about it because of its linkage to sex and the early adolescent age of the recommendation for administration. It made for uncomfortable conversations between parents and their kids' pediatricians. And something I like to point out, though, is that nobody ever made the hepatitis B vaccine about the behaviors that it prevented against. I certainly didn't have that conversation in the hospital with the pediatrician after any of my 3 children were born. And my point is that uptake was slow, perhaps slower than it needed to be. And so we find ourselves where we are. The indication for boys in the US came in 2009, but 3 years of initial messaging were hard to overcome and uptake was slow among that group, as you can see on the graph. Then in 2014, Gardasil 9 was improved. It really upped the ante to cover 7 of the most common types of oncogenic HPV and continued to protect against 6 and 11. And the main trade-off was that the shot hurt more. All of this that you already know to underscore a few points that are going to be important for this talk. Our initial messaging wasn't great. There's been a lot of change in a relatively short period of time for people. And with those things in mind, you can start to see why some folks might harbor misperceptions and why we're not quite hitting our coverage goals. So we know that there's commonly held myths, and these can be corrected among those who are willing to engage, but there's a wide variety of constructs that lead people to be hesitant about the vaccine. Some are knowledge-related, perhaps, some are the results of feelings or stigma or bias, and others are related to deeply held beliefs like religion. So we have this term misperceptions, and these are a combination of falsely held beliefs, limited knowledge, and negative attitudes about the HPV vaccine. Ooh, I'm skipping ahead. There have been a lot of scales to assess parent vaccine knowledge, beliefs, and attitudes separately, but there were very few that were focused solely on HPV vaccine and really just getting to the bottom of why people were hesitant about it. And among those that were focused just on HPV, those scales, they never were really assessed against actual vaccination of age-eligible children. And so we developed this HPV vaccine hesitancy scale or misperception scale with 12 items in it, and you can see them listed here. And this has been published in a paper in the Journal of Racial and Ethnic Health Disparities and another paper under review at Vaccine right now that shows that this is a valid scale. And not only is it a valid scale and a reliable scale, it actually is related to whether parents vaccinate their children for HPV. And so what we found was that for every standard deviation increase in parent HPV vaccine misperceptions as measured by the scale, there was a doubling in the odds of them not vaccinating their kids for HPV. Now, a lot goes into parental decision-making about the HPV vaccine. One of the most important factors is a strong provider recommendation, which we all know. But when we say provider, we typically mean physician, and there are others in the pediatric or family practice setting that interact with patients and parents and who have credibility and a uniform along with the comfort of someone who might be a little bit less intimidating. In fact, there are people who typically speak to the parent and the patient dyad about the vaccine before the physician or the advanced practice nurse even enters the room. And they're the ones who typically administer the vaccines. And of course, I'm talking about medical assistants and licensed vocational nurses. And from that first interaction, there's an opportunity to calm fears or an opportunity to reinforce misperceptions. And there have been a few studies that have included MAs when they assess pediatric practice, HPV knowledge, and hesitancy, but usually the sample sizes of the medical assistants in those studies is very small. We can see some trends, though, that as you go down in the medical hierarchy, vaccine hesitancy tends to increase. So we set out to conduct a study focusing on MAs and LVNs to find out who they were, what they knew, what they're asked to do in their practices, and whether they might harbor misperceptions about the HPV vaccine. We didn't want to bite off more than we could chew, so we stuck just to California for the study. In order to be eligible, participants had to be MAs or LVNs in pediatric or family practice settings that had contact with pediatric patients and their parents in exam rooms. So essentially, they're in the exam room, they're talking to the patient and their parents. We started out with just a simple cross-sectional study, and we recruited from last July through December using a triple-pronged approach. We started by doing direct outreach to California members of the American Medical Association. And everyone on that list received a unique link to screen if they were eligible for the study. And if they were eligible, they entered right into the study. We also did a lot of direct in-person and phone outreach to clinics to recruit, and we leveraged our networks through our cancer centers, through the American Cancer Society, and the California Dialogue on Cancer, and the immunization coalitions to reach clinic and health systems through email and newsletters. But by far, what we found was the greatest approach was actually sending research assistants to clinics around the whole state of California. They really got to travel and see the state. and to actually go and talk to the staff and encourage their participation. So we offered an incentive for this study, and anytime you offer an incentive, you're going to have people who try to take advantage of that incentive. And we were inundated by thousands of bots at first. We solved that problem, and we had already baked in a process to make sure that people were real and people were eligible. Because I had a taste of this during COVID with the bots. So to ensure that people were eligible, anyone who is contacted outside of that direct AAMA email list had to complete the brief eligibility questionnaire online, and they had to have a video call with one of our study personnel. And they had to verify that they had a California identification and either a pay stub or a badge to show that they worked where they said they worked. And so we were pretty careful about that. We really didn't want people in our survey who weren't supposed to be in our survey. Once they completed that video visit, they were sent a unique link that only they could complete, and 97% of those links were used to complete the survey. So that was pretty good. The survey itself was 50 items, but it only took about 12 minutes to complete. Once it was complete, respondents received a $30 Amazon gift card. And in the end, we had 459 valid surveys to analyze, which I was incredibly proud of. So going a bit deeper into the survey itself, we're assessing the work environment and the experience, including what tasks they're asked to perform related to immunization in their practices. We also included our validated 12-item HPV vaccine misperception scale that I already showed you, and several additional items around HPV vaccine beliefs, like the acceptability of delaying the vaccine or sexually stigmatizing beliefs about the vaccine, and trust in physician recommendations. We also developed a 10-item knowledge battery, and we asked a lot of socio-demographic questions like religious affiliation and language fluency. So I'm going to hop into the results now. So on average, our median age was age 34 years, and participants had worked an average of 7 years in their position. The median hourly wage was $25 an hour. 93% of the participants were women, 6% were men, and 1% were non-binary. We asked about the highest level of education that they had completed, and more than 2/3 reported on-the-job training, vocational school, or a certificate program. An additional 22% had an associate's degree, and 11% reported that they had a bachelor's degree. And so a lot of vocational school or just on-the-job training. Again, that was like 67% of the people that we surveyed didn't have formal education through college. We also asked about religion, and nearly half were Catholic, and another 20% were some other denomination of Christianity. And about 1/3 of respondents reported that they had no religious identity. So we were interested in really exploring how religion impacted people's beliefs about the HPV vaccine. You can see in the chart that the most common race and ethnicity of respondents was Hispanic or Latino, followed by white, and then by Asian. And more than 2/3 of the people that we surveyed reported speaking a language other than English. And 86% of those that spoke a language other than English spoke Spanish. So a lot of multilingualism, which is wonderful, and goes back to the idea that these folks might be a little bit more trusted or have kind of instant rapport with patients that physicians may not have. So we ended up with a really nice distribution of setting, which I was also really excited about, with a relatively even split between those in private practices, those that were in practices that were health system owned, and those who worked in safety net settings. So that could be FQHCs or rural health clinics, things like that. Most of the people who completed our survey were MAs, and we had a portion who were licensed vocational nurses. And about half were supervised by a physician, and about half were family practice, and half were family medicine, sorry. So half and half. So this is where it starts to get really interesting. We asked people what they are asked to do in their practice. And you can see here this giant slide of bars. And so some of these make a lot of sense, right? 96% of people screen the medical record for immunization status. 90% of them assess the child's immunization status. 84% inform the parent that the child is due for the HPV vaccine. They're also drawing up and preparing the vaccine. They're administering the vaccine. They're documenting the vaccine. They're reminding families about future immunizations. They're taking patient vitals. They're rooming the patients, and they're reviewing after-visit summaries. We also asked, do you make recommendations about the vaccine, specifically the HPV vaccine? And 70% of them said that they are, in their practice, expected to make recommendations about the HPV vaccine. Almost 80% said that they answer patient and parent vaccine questions. And so there are conversations going on, right, between the MA and the patients and their parents about the HPV vaccine. And another 68% said that they address parent concerns about the HPV vaccine. So what this tells us is, again, that these conversations are happening. So then we asked about their knowledge and about their misperceptions. Unfortunately, knowledge was relatively low. So I told you we did a 10-item knowledge battery, and the average score out of 10 was a 5.6. 66% of people who completed the survey had 6 or fewer of those 10 questions correct. And misperceptions were somewhat high. So the mean score, it could range from 0, meaning no misperceptions whatsoever, all the way to 36, meaning you are off the charts with misperceptions. So 0 to 36, and they had about a 10.9. And that was only slightly larger than a sample of just average community members that we did. So again, higher scores are associated were associated in parents with not vaccinating their age-eligible children. And so we can say that perhaps higher scores in MAs might be associated with not advising parents to vaccinate their age-eligible children. So the bigger question that I had was, well, how do these knowledge and misperceptions vary by different factors? Because that matters when we're thinking about what to do about this. So when we're talking about HPV vaccine knowledge, we saw that it actually increased with age. And so older MAs and LVNs had greater knowledge than younger MAs and LVNs, which was actually the opposite of what I had kind of had in my head when we were creating this survey. I had thought that the younger folks would have been more exposed to HPV vaccination and perhaps a little bit more in tune with it, but it turned out to be the opposite, that increasing age was related to increasing knowledge about the HPV vaccine. So experience perhaps is what's driving that. We also found that HPV vaccine knowledge was lower among those with no formal HPV training, which might make a lot of sense to you, but hadn't been documented here in this population. And when we looked at it, it didn't vary by whether they spoke a language other than English, what type of specialty they worked in, what type of setting they worked in, or their role. So not a lot of differences in HPV vaccine knowledge by those kinds of factors. And then when we look at HPV vaccine misperceptions, and again, higher scores mean you have greater misperceptions, it was higher among multilingual respondents than monolingual English respondents. And misperceptions were higher among those with no formal HPV vaccine training compared to trained respondents. It was lower among those with a bachelor's degree, which makes sense. The more education you have, perhaps the lower your misperceptions, but it didn't vary by practice specialty, clinic setting, or role. Now, it's important, and why we looked at whether it varied by specialty, clinic setting, or role, is that when we're thinking about interventions, we wanted to know if we needed to tailor interventions by any of these things. And the fact that none of these vary by specialty, clinic setting, or role means that we can create a pretty broad-based intervention that can be given across all of these factors. So before I go on, I need to just give you a little bit of information about my background. So during the pandemic, I pivoted to support San Diego County communities for an equitable COVID response. So I'm usually a cancer researcher, but I was in a community advisory board meeting in March of 2020, and we were talking about cancer, and they said, "Corine, we get it, you do cancer, we need help with COVID right now, what can you do?" And I took that to heart, and so I pivoted my whole program of research and practice. And it started with a community health worker-led contact tracing program where my team and I recruited community health workers to conduct culturally and linguistically concordant contact tracing and to do home visits. And this was in the very early days of COVID. So summer of 2020, we were on the ground doing contact tracing way before we had a vaccine. And so I went on to help lead community health worker-led testing and vaccine support interventions that were all based on the work that I did with contact tracing. And what I learned is that the community health workers that we recruited and trained for this didn't have formal training in COVID, right? But they were eager to learn, and they were waiting for someone to see them, to see their value, and really empower them to support their communities. So I developed these training programs that included weekly AMAs. And if you're not familiar with the term AMA, it's a Ask Me Anything, because COVID was changing moment by moment. And so every Friday we would gather for these Ask Me Anythings. So ask an epidemiologist any question you want. And they could give them to me ahead of time, or they could put me on the spot. They could give them to me anonymously, or they could raise their hand during the meeting. And they could bring any question, and they could say that they heard it from a friend. Anyway, there was no judgment. That's my point. And this really built their confidence in the information that we were giving them because they were allowed to challenge it. They were allowed to kind of ask probing questions because when they came to us, they were not instantly pro-testing. They weren't instantly pro-vaccine. They actually had quite a lot of vaccine hesitancy, and we needed to earn their trust. And I see this work with medical assistants very similarly, that they have the trust of the communities, and we really need to empower them, not just with knowledge, but by seeing and valuing them in their role. So now that I've digressed a little bit, let me go back. So this, in California, the MAs and the LVNs that we assess that work in pediatric settings are an incredibly diverse workforce. And they may have this kind of innate trust and rapport with parents in medical settings. And a lot of them are currently advising patients and parents about the HPV vaccine, but they have limited HPV vaccine knowledge and somewhat high HPV vaccine misperceptions. So this represents an opportunity to really intervene and support a positive role in these medical offices. Now, the challenge is that medical assistants are not licensed, at least here in California, and are not required to do any continuing medical education. And so any efforts that we create are really going to be health system by health system to gain the ability to access these medical assistants. So the study, again, was a single state study. We just did it in California, but it's a pretty big state, and we had really great representation from across the state. Again, my research assistants were so excited to travel around to all the different places and recruit people. We did have really good representation across practice types, so we know that things are pretty similar in private practice, in safety net settings, and in health system-owned settings. We verified participant eligibility, so we know that these people are who they said they were, and we used validated measures of misperceptions. But this is a one-time study, and we have to be careful about the conclusions that we draw with one-time studies. And we didn't directly observe anybody, although that would be really fun. And the people who chose to be in our study might be different than the people who didn't choose to be in our study. So there are some limitations that we need to take into account when we're thinking about these results. One of the things that I asked in the survey at the end, when they went to claim their incentive, they had to go to a different form because we didn't want to link their identity to their responses. And in that incentive form, we asked if they would be willing to participate in future research. And most of them said yes. And so we're doing what's called a nested qualitative study with these folks. And we're designing those qualitative questions now to really go deeper on a lot of the things that we learned and to clear up any confusion that we had about questions that they answered. And then I really want to work on an intervention around knowledge and empowerment. And I'm trying to develop a multi-level intervention to submit as a grant. And I'm going to pause there and thank you for your time. And I'm happy to take any questions that you might have.
Oh, sorry, I am on mute. I'm sorry. I was thinking, I love the chat, Dr. McDaniels. I was saying that I'm moderating the Q&A, and there is a question from Irene. If you can see that, are there any concerns about how MA should message, given that their scope of practice does not permit giving advice?
This is such an interesting piece of the puzzle, and one that I really wanted to explore a little bit more with the qualitative study that we're doing. Because you're right, it is not in their scope of practice to give advice, and yet we found that many of them are giving advice. There has been research done on this that has found that they do operate within their scope of practice, and so our findings are in opposition to what's been published. And so again, that's why I really want to clear that up with the qualitative research, because I want to find out what's actually happening in exam rooms. And short of going in and observing, which then changes things in and of itself, we need to talk to them and find out a little bit more about that, because we don't want them practicing outside of their scope.
Yeah, this is Irene. I asked that question. I'm a retired pediatrician, and I'm currently, I think, the California trainer for announcement approach training. And I think you could, once you figure out what's actually happening and then decide whether and how you want to change it, I think you probably could train them to say, Dr. Landau, that's me, feels very strongly about HPV vaccine for her patients. So I hope you'll ask her about it today. They're probably allowed to do stuff like that. If we ask them to actually promote the vaccine themselves, I think we're at a risk of having them practice outside their scope. But it'd be interesting to, I know you're going to look into it further. It'll be interesting to hear what happens.
Yes, I was actually quite surprised by the findings.
Yeah.
Hopefully I can get in touch with you when I do the qualitative part.
They know where to find me.
Any other questions for Dr. McDaniels? You can put it in the chat, or feel free to unmute yourself and ask your question.
So I didn't get a chance to tell you all why I started thinking about this. And I did mention that I have 3 kids. And so when I first took my oldest daughter in to get for a little well baby visit, I remember the MA said to me, "Oh, Abigail's due for 5 different vaccines today. Do you want them all today, or do you want to space them out?" And that kind of put me on high alert. And so I just tracked over time, and I talked to the pediatrician about it and about what the conversation was like, and she said that she would address it. So years later, I was so excited because Abigail was now turning 9. She's now about to turn 12. So this was 3 years ago. She was turning 9. I was so excited to find out how they were going to talk to me about the HPV vaccine. And I went in, and the MA said to me, "Oh, Abigail can get her HPV vaccine today, but this is for a sexually transmitted disease. So do you want to wait for it?" And that's when I decided it was time to do this assessment.
Well, bless you for doing that. This is Irene again. I discovered in my practice, I'm retired now, but we had a protocol where patients could come in and see a registered nurse who would order their vaccines that were due by protocol. We had a standing order, I guess. And my LVNs were the ones who were doing the majority of the vaccinations, and they were vaccinating kids that had an order on the same day, and they were all very well trained in what to do, but the orders were coming from the provider. So I noticed that I was in charge of immunizations for my department, and I noticed that I had a lot of patients coming in who had come in to see the nurse, the registered nurse, and had said, "I got this letter from my kid's school that they need these vaccines for 7th grade," or whatever it was. And then the nurse would order the meningococcal vaccine and the Tdap or DTaP, TD, DTaP, whatever. And the kid would not have gotten the HPV vaccine. And I noticed this was a pattern. So I went to my registered nurses, and with the help of some parents, I did my own little non-numerical study, qualitative study, and I discovered from the parents and then confirmed with the nurses that they would say, well, your child also needs the meningococcal vaccine because the Tdap was required and the meningococcal was not. Um, and do you want them to get the HPV vaccine? So they were clearly presenting two of the three vaccines as a recommendation and the third as a question. And so I needed to do a lot of work with my registered nurses, not with my LVNs. And honestly, the MAs didn't occur to me because they were unconsciously dissuading the parents from getting the HPV vaccine, and we needed to fix that.
And I think you brought up that word, and that's exactly, it's so important because it's not necessarily a conscious bias, and it is unconsciously kind of undermining vaccine recommendations. And I think once we point that out and address the concerns that they do have, then we will see improved communication.
Agreed.
That is what we saw with the community health workers. And boy, did they have questions.
Dr. McDaniels, there's two more questions in the chat for you. And Allison has her hand raised. You want to answer Allison's question first, and then we'll do the two in the chat.
Sure.
Is that okay? I literally just raised my hand, so.
No worries, Allison, you can go first.
All right, let me turn on my camera so we can all see each other. You would think that would be, haha, here I am. Got a little leg. Hi. And hi, Corine. Thank you for this talk. And as you know, I've been like pounding this drum for a long time because I do think this is really important that we consider the entire medical team. And I do think that patients in many settings really do trust the MAs because they see them as peers. So I think they might have, strong physician recommendation we know is really powerful, of course, but I do think they really trust what they're hearing from these folks who are peers. So I'm curious, there's no right answer, but I am curious as we move forward in the current political climate, and we have the moms and all of this stuff and a lot of vaccine skepticism increasing, and that's very, very worrisome. I wonder sort of what you think about that, given what you shared. I didn't realize there was no continuing ed required for MAs and folks like this. So I mean, I think we're all influenced by the things that we see and hear online, but as increasingly it becomes more negative towards vaccines, I think it's going to be even more important to intervene and ensure we have some type of education across the whole care team. So I just wonder if you have thoughts about that or kind of think about that, because I know you gathered your data before all of this happened.
Yes, I have a lot of thoughts. And you're right. I can remember when we were talking about this years and years and years ago. So there are challenges presented with the current administration. Some of the challenges are things like, I am not going to get funded to do HPV vaccination work through the National Cancer Institute, and I need to find alternative sources of funding to continue this work and to develop interventions. That's a me problem. The bigger problem that you're talking about is a societal problem where we have this kind of this skepticism of expertise and this very populist kind of movement, and it's really enhanced by social media, and it's enhanced by the current administration and the talking points coming out of Health and Human Services. And it's a little scary, but right now we still have some things on our side, and we have health systems that want to improve vaccination rates. And we know that by vaccinating, we can save people bundles of money in treatment later on. And so those things are still a little bit on our side, and hopefully they'll continue to be on our side so that we can get the buy-in of health systems to help continue to increase the vaccination coverage of these age-eligible youth. I see a lot of similarities with COVID, and I wanted to forget those 3 or 4 years, but I see that I'm never going to be able to, where there's a fire hose of disinformation and misinformation about the vaccine and about vaccines in general. And it's really hard as a scientist or for my physician colleagues to fight this fire hose of misinformation and disinformation because nobody fact checks what they're saying. They just get to come up with something else to put out next. And meanwhile, we're so careful about our words and we're so careful that we are exactly correct. And we're behind now by years and years of misinformation and disinformation. I put up those myths and facts, but they've evolved even in the last few months of what people are now saying about the HPV vaccine. And so it can be really difficult and it can be dispiriting to be on this side of things. But I think that again, we have lots of things on our side and we just need to keep up this fight and know that we are saving people's lives by ensuring coverage of this vaccine.
Okay, Dr. McDaniels, you have 3 questions and no time. If you can just quickly click one.
Oh, thanks, Corine. I appreciate it.
And we put the evaluation in the chat too. So if you could fill that out while you answer these last 3 questions.
Sure. Can you point me to the questions or could you maybe read them to me?
Okay, yes. The first one is, do you see this strategy being expanded to other areas outside primary care, face-to-face visits, example, telehealth visits or nurse-only visits?
That's a really good question, and I haven't thought a lot about it yet because I still am designing the intervention for the face-to-face. But I think it could be really important in those contexts as well, and I'll start bringing that into my study meetings and chewing that around.
Okay, the next one is, can you talk a little bit more about this 1-hour training at the provider site and where can this information be found?
I think that's for someone else.
Oh yeah, I put it in the chat for Christy.
Thank you.
Okay. And then the last one is from Jane. The question is related to the presentation. Can MAs administer vaccines under standing orders in California?
I think I need a physician to answer that one.
Yes, they can, under standing orders.
That's why it's so important to have a physician colleague along with the researchers.
Okay, and I think we got all of the questions. So one last call out. Anyone else have additional questions or comments? If not, we want to thank you so much. This is a great presentation, and Joyce has the rest of the learning collaboratives.
Thank you.
Thank you so much. Bye, everyone.
Thank you. Yeah, join us for the next one, October 15th. We look forward to getting your feedback, and if you're interested in presenting, happy to have you volunteer. Thank you. Bye.